This is Pulmonary and Critical Care in Neuromuscular Disease, and we are joined by an amazing panel of experts who I call my dream team. Let's have you guys introduce yourselves. We'll start with Mimi.
Hi, I'm Mimi Boo. I'm a pediatric pulmonologist at Stanford University, and I'm really happy to be here. We were prompted to say what brought us into this field, and I really think it's one of my lucky breaks because I was just at the right place at the right time when there was a need for expertise for people with condition and muscle weakness, and I really loved the community ever since.
Hemant Sawnani from Cincinnati Children's. I want to thank all the organizers in organizing this meeting. I've defaulted, not been here for a few years, but I'm glad to be back. I have been affiliated with Cure CMD now for 17 years, something like that.
17.
Something like that. And I got into this happenstance. I think it's the right place, right time, and people asking the right questions. So here I am.
My name is Mark Sketch. I'm the respiratory therapist that works in the neuromuscular clinics with Dr. Pascoe and Dr. Sawnani. I've been working in that clinic for 10 years with them, and just very grateful to be around people like that care so much for all muscular dystrophy communities, but really just very happy to be here. And I chose this 10 years ago because I really, all of these communities, I have a heart for all of them, and it's been so fulfilling for me to learn underneath these guys. So I'm just happy that I'm here and happy that I'm in that clinic with them.
Hello, I'm John Pascoe. As sort of preface, I'm at Cincinnati Children's, pediatric pulmonary, and a sleep background as well. There's a reason Mark is sitting between Hemant and I. I'm just kidding. We get along, don't worry. But I sort of fell into it as well. Undergrad, I was sort of like neuroscience, biopsych major, so sort of that neuro aspect, and then peds pulm. Eventually realized that's where I wanted to be, just seeing kids moving around, walking around with trachs and vents, and knowing that I could do their scope, I could manage their sleep study. I eventually did sleep. Hemant brainwashed me. It took a while for that too, but and very glad that I did. And it helps sort of fine-tune your eye for the nuances within people with neuromuscular disorders. So, and just wanted to also say thanks for the invitation to be here. It's always one of the favorite conferences, absolutely. And the app is really good, so thanks. Many times these apps are not very functional, but this one's great. So
Yay!
Hi, everyone. I'm Oren Kupfer. I'm a pediatric pulmonologist in Denver, Colorado. I've been to a few of these meetings, and each one is more inspirational than the previous because I get to meet such wonderful parents, kids, and young adults with neuromuscular disorders. I also fell into this field a little bit out of luck, and I'm proud to now be in the community for 12 years practicing, and I couldn't imagine anything better. Thanks for having me.
Hi, I'm Rich Kravitz. I'm a pediatric pulmonologist and also a sleep physician. And I'm at the University of Virginia now, but I got into this when I started my faculty career way back in the day, just down the street at CHOP. And I worked with a pediatric pulmonologist, Craig Schramm, who every Friday he had this clinic with guys in wheelchairs running around, driving, trying to knock over as many people as they could. And I asked him, what are you doing? And he goes, well, I run this respiratory dystrophy clinic for children with neuromuscular conditions. And I found it to be fascinating. And I kind of watched him and kind of drank the Kool-Aid. And after I left CHOP and I went to Duke, I started building a program there. But I also met a gentleman at CHOP, Reghan, who was a real great sleep physician, one of the first generations, and I watched what he's doing and go, I like this. So again, I drank that Kool-Aid, got boarded in sleep, and then I've used the two, just as was previously discussed, as they feed off of each other. And then, as LeBron James would say, I took my talents to Charlottesville and University of Virginia and have been helping them continue to build up their program. But I feel like everything came together. This is my bliss, my passion. Love taking care of the kids, working in the family groups like here, Cure SMA, PPMD. I just meet wonderful people, wonderful families, wonderful children. And, I like to think of this as our pediatric pulmonary posse. And it's just great people that I hang out with. And so thank you for having me. It's just a pleasure to be here.
I'm Reghan Foley. I'd like to thank the Pediatric Pulmonary Posse for letting me to sit on this panel. I'm a pediatric neurologist, a neuromuscular specialist. I also trained down the street, Children's Hospital of Philadelphia. I had joined Dr. Karsten Bonneman one day when he walked a clinic. It was neuromuscular clinic. I met collagen 6 patients, collagen 6 muscular dystrophy, other CMD patients, and congenital myopathy patients, and I haven't looked back. There's nowhere else I'd rather be than with my people, as Rachel knows, I call you my people. And the reason why I think I am allowed to sit up here with the rest of the pulmonologists is because I spend a lot of my time talking to my patients about optimizing their pulmonary care, and which also translates to optimizing your quality of life.
Awesome, thank you. I've got my slides on my phone, so we can ignore that. I have a couple questions that I'm going to start with, but I want you guys to start thinking about your own questions, okay? So my first question, I have 2 questions I want to ask first. For all of you, what's the most important aspect of your work, and what have you learned from families to make you a better clinician? Reghan, we'll start with you.
Okay, most important aspect of my work, I think, is and also the most enjoyable is being able to tune the radio station into the patient when he or she's in front of me and have them be on the air and then hear them tell me about their life, which is so much more than just what their condition that brought them to our clinic for, and then being able to figure out how we can optimize those little bumps in the road that might bring them to the ER or hospitalize them. What have I learned from my patients? Resilience, that strength is not something made at a gym. It's how we deal with adversity in our life, and that joy can be infectious and joy can be palpable, like this weekend. So,
yeah, it's funny. We all are pediatricians in one form or another, and love of children, taking care of kids, taking care of families is what got us into this field. And one of the nice things about pulmonary is a lot of specialists put their blinders on, and I'm just looking at this, I'm just looking at that. And because there's so much general pediatrics in pulmonary, we get to kind of be a general pediatrician. We drive in our lane, but we look around us and see what's going on. So I get to be a specialist, but a generalist too. And I feel like that really makes it for a more rewarding day. What the families teach me, I've learned so much from families, how to manage adversity, things that might get me real frustrated, and I look at my families and they just, whatever, let's shake it off and move on. And it's great. And they always see the glass as half full. And I love taking that optimism home. It helps recharge my batteries. So just seeing the hurdles that you overcome gives me resilience that I can then take, they say, steal shamelessly, credit generously. I learn things, I pass them on to families, they pass them on to others. It's just a real great community.
Pass.
Stop it. Just stop it.
I actually learned how to care for kids for my patients. You can read a textbook, you can read papers, but to actually take care of a child is so much different than what's on the page. And so I learned how to enjoy doing the job that I do because it's for the sake of a very special person.
So and first and foremost, in first, second, and third, it's treat the patient, not the disease, right? So I completely am very much motivated and inspired by all of you. It keeps me going, absolutely. Being sleep trained, I have my sleep clinics and my neuromuscular clinics. I enjoy it all. In truth, though, I really, really enjoy the neuromuscular clinics, and that population, the community is incredibly inspiring. And I think just as what's been mentioned too, you can read in the textbooks, everything like that. There's lots of things we don't think about necessarily that you all experience day in and day out. And how can we help you to improve quality of life? And to that standpoint as well, we don't know everything. We've made a ton of advances in medicine, but we absolutely don't know everything. And even some of the things in textbook, it's like, that's not supposed to happen, but it clearly is. So let's think outside the box and how we can maybe help that too. So I think you all have taught me to try to listen as closely as possible and absolutely not brushing anything off and trying to dig deeper and see if there's a solution. And a lot of major institutions have their policies. We can't do this, we can't do this. Well, sort of why? And we can try to break down some of those policies and like, if this is gonna help the patient, then we really fight for that too. So I think the inspiration you provide us helps us to motivate and improve care altogether, so.
The best clinician that you can have is the one that says, I don't know.
I think the most rewarding part of my job is working with these two mad scientists here that come up with ideas for breathing mechanics, and sometimes they're just a little out there, but we always get to where we want to go by brainstorming together and just kind of working through the process to get our patients to a higher level of breathing. I think one of the things I've learned from patients and families is that not everybody's the same. I think that was said before, and that how you treat one patient is not how you're going to treat another patient in a family. And so I've learned over the years to develop an individual plan when I'm walking in a room and talking with them and finding out what motivates them or how we're trying to get there, but making the connection first before telling them, this is what we need you to do.
There are so many layers to this simple question that she asks. So on a professional level, I feel extremely fortunate. When I started at Children's, I was by myself for a little bit, and within a couple of years, when I needed help, my chief was like, sure. And the fastest thing he could give me was a nurse practitioner who's still with us today and is phenomenal. I trained her, and she flew. Then John comes along and says, I want to do this. And so at a professional level, I'm surrounded by people who see value in what we do. They are inspired to take on of this part. And so one of the joys I have is mentoring. And I didn't recognize that until the team expanded to all of those that we trained and took on. On a personal level, I feel like when I meet each family in clinic, it's incredibly humbling. And I come away always learning something new. Not necessarily about them sometimes, but a little bit about myself. And I think we need to be more grateful as a population. And it teaches me that on a daily, moment-to-moment basis. So if anything, I'd say the career has picked me and taught me to remain as grounded as possible. And then I get to hang out with people like this. So this is my R&R. That's what I was telling some folks yesterday. I come away from Cincinnati to take a break from Cincinnati because I get to hang out with people who I get to see maybe once a year or once in 2 years. And it's a joy for me to be here.
True story.
I echo everything that's been said. For me, for some of the families that know me, I am a early adopter of technology and knowledge that the scientific community brings together. And my relationship with families is how do we partner together to actually make it happen? So that's one partnership. The other partnership is I feel like often I'm a translator. Like what does this data actually mean? What does it mean to you as a person? And how can I help you? And I think that that's different for every individual. and every family that I work with. And I learned so much from the families where, I read guidelines or I'm on guidelines and we say we should do something, but then how do you actually make it happen for the families? And is it even right for that patient? And we learn a lot about everyday life and how do you actually make it work. I love the first session about PT and all the different therapies that are recommended. How do you prioritize? And I think it's a conversation every time, and that's why we see each other, right? To help talk through what is a priority right now, what are your goals, what do you want to do, and help. We have some expertise to help you through those conversations and through those decisions.
There's not enough time in the day to do all the things doctors want you to do.
That's right.
So priority is key. Mm-hmm. All right, Dr. Sawnani, in 90 seconds or less, describe how neuromuscular conditions impact breathing function. Go.
Okay, so I'm going to start speaking very fast, and you can meet me after that if you have any questions.
Sounds like the dating game.
So, it boils down to primarily two aspects of the chest wall. We recognize that it's a multi-jointed structure, and all joints need to move. When they can't move, you have impact. And the second thing is there's muscle between all of these bones, and the muscles are a little weaker, and that sets the multi-jointed structure to get stuck. It's a setup. And so as I think about what I like to call kinematics of the chest wall, which is the movement in 3 dimensions, I really think that the first decade of life, or sometimes a little earlier, particularly in some of the CMDs, is really critical in making sure that everything stays flexible, pliable, and mobile. If I simply ask you if you have to push a car with 4 inflated tires or 4 flat tires, the automatic answer is going to be a lot harder to push with 4 flat tires. And so what you're dealing with conceptually is the concept of inertia. So a stiff chest wall is much harder to move, and that has its downstream side effects, which is what we see when we do our pulmonary and clinical assessments. 90 seconds?
Awesome. All right, who's got questions?
Morning, everyone. It's morning still, right? Anthony Parisi, my wife Molly. We have a 7-year-old with Lambda-2, was diagnosed at 5 months. Like many, if not all of us in the room, pulmonary, right, continues to be one of the most, if not the most critical area of his care and sort of our journey as parents. And before I get to my question, just want to make a comment. Appreciate all the words you're saying about treating the patient and not the disease, and really getting to know the family members, because, from our point of view, that does mean a lot. And probably speaking for the room, just wanted to thank you for that perspective and for those words. Reghan and Rachel continue to be lifelines for us. In fact, I have an email queued up to both of you with the question I have, so I appreciate your help as always. But my question has to do with the relationship between sleep medicine and then traditional pediatric pulmonary. And if locally, we are fortunate to be under the guidance of Dr. Pascoe, fantastic doctor. We're lucky that he's there in Buffalo with us. But from the sleep side, we feel like the University of Buffalo has sort of started and stopped a little bit. There is a practice. We've built some momentum. We've had sleep studies. James sleeps with a BiPAP at night. We've got guidance on that. But we feel like we should be doing more in this space, right? From the clinical side to us. We just feel like there should be more. And whether that's true or not, we can ask the questions and kind of work through that. But if you guys could just talk about the importance of treating both sleep and traditional pediatric pulmonary and why that's so important, and maybe give us some guidance as we go home for others that are like us, where we feel like we should be doing more. What can we bring back to our local teams just to underscore the importance of treating both sides of that?
Since you had the 90 seconds or less, I guess I can try for this. I don't know if it'll be 90 seconds, though. And I was actually I can't say anything more to what Dr. Sawnani said, except for understanding the impact of muscle weakness on respiratory mechanics. But then there's the additional component of sleep. So understanding how sleep changes compared to normal function. So I think perhaps stepping back and just saying, what is normal sleep like, right? And so when we fall asleep, our CO2 levels will go up a little bit. Our oxygen levels may come down a little bit. We have just automated breathing taking over. And then during dream sleep, you lose muscle tone. And so, and it's, I think evolutionarily, so we don't beat each other up acting out our dreams. Like, I don't know why else potentially. If you do, like, consult a sleep physician, because it's not normal if you're perhaps beating your bed partner at night, not realizing it. But so the fact that's really important is that when, especially with some neuromuscular diseases that will have some progression and will progress through from ambulation clear through to non-ambulation. I know this isn't a Duchenne conference, right? But Duchenne is one of the sort of paramount sort of examples of this, is that eventually you go from a point of being totally fine and not having any sleep symptoms to all of a sudden having some very subtle sleep symptoms maybe, and then having more full-blown, and that you need some help with breathing. And so I think in terms of your question from the sleep standpoint is recognizing what some of those signs will be. In that, yes, there's traditional snoring, pausing, gasping, and kids' restlessness. In general, we don't consider snoring in pediatrics to be normal. And in our culture, a lot of, in a sleep visit, I'm sure with any of us here, you ask about snoring, it's like, yeah, but it's not as loud as dad, it's fine. And so it's like, yeah, okay, great, I'm glad that's the case, but we still probably should look into this. Some patients don't have any symptoms at night, but what you might find is that they wake up a lot at night, right? And so it could be, I'm waking up to be turned, but actually what caused you to wake up to be turned? One question I think of is it cyclic? So we hit dream sleep every so often, right? And if you're waking up every hour and a half, 2 hours, something like that, it could be that you're hitting, your child or loved one's hitting dream sleep, having a respiratory event and waking up. And then it's, oh, hey, can you turn me, right? And so there can be some of these more subtle signs. Is there napping during the day? Are we having restful sleep in the morning when we wake up? Are we nice and well rested? Are you sleeping much, much longer than what's age appropriate? That can be a sign too of having issues. A morning headache right away could be a sign of carbon dioxide retention as well. So in terms, there's these, and the general pulmonologist, I would say, can recognize some of these, but not, I think some of the softer signs of not having snoring, maybe not actually would recognize, but having the questions of routine awakening is something that requires you to have some of this background knowledge. And I don't want to, I'm sort of covering a lot of ground here. I want to save some for Rich too here. The other comment about, so reading sleep studies. So a lot of places are set up for adults. Adults, it's not mandatory to be monitoring carbon dioxide levels. In kids, it's like paramount, and especially in neuromuscular disorders. In fact, in adults with neuromuscular disorders, you should be monitoring CO2. Home sleep studies for pediatrics, not a thing. Maybe, unfortunately, right? Because the sleep study environment, it's more of a sleep less study than a sleep study sometimes. But we can get good data from it, even though it's not a typical night of sleep duration-wise. As long as we have like 3-4 hours, and especially if we can see dream sleep, it's very, very helpful. The sleep studies, the output that we get from it, it doesn't necessarily capture some of the qualitative things compared to the quantitative. So what's your O2 level? What's your CO2? Sure. What's your respiratory rate? Sometimes that's outputted, not always though. But it's also, what is the respiratory rate during dream sleep? What is it during non-dream sleep? What's your CO2 doing or O2 during dream sleep? These are some small nuances that software doesn't necessarily spit out, but requires somebody with a watchful eye and knowing the diagnosis when they're reading the study to be able to identify. And so not all sleep centers are created equal, in truth. Some of them are more, and you might actually see, if your child has OSA, you'll see on the report saying, recommend seeing ENT for a TNA, or tonsils and adenoids coming out. In neuromuscular medicine, not really the case. There are rare exceptions, I will say, because sometimes we'll have families reach out and say, this was recommended, this is crazy. And we're like, no. I think you may be strong enough and taking the whole picture into mind that it might be the right approach, and that's okay. But by and large, not the right approach for neuromuscular. I'm going to stop there. That was much longer than 90 seconds.
Longer, but incredibly comprehensive, and you hit pretty much all the topics. So a lot of pulmonologists like to think of ourselves as physiologists, and we look at what's happening within the body. And we'll approach, Oren is an outstanding pulmonologist who's not a sleep physician, Same for Mimi. We approach things, what's going on with the chest wall motion, breathing, getting oxygen in, carbon dioxide out. I think as those of us who are sleep physicians, we get to add another layer of nuance onto that, understanding like the cyclic aspects of REM sleep, what's going on. If a patient's waking up multiple times a night, is it because they need to be repositioned, or are they waking up because they're having sleep distress and, oh, by the way, I'm up, will you reposition me? So we ask these questions to kind of get a 360 view of a child sleep. But it's also important that we look at what is normal sleep for a 7-year-old who doesn't have a congenital muscular dystrophy. What's the normal expectation for that? And our goal is to get that child to what their sibling might experience who's not affected. So we're looking at the physiologic aspects, the airway collapsibility aspects, and we're looking at what is normative behavior for a child or young adult that age. Our teenagers, and if you have teenagers, know they like to go to bed at 12, 1 o'clock. That's normal. The problem is if you are dependent on caregivers to help get you ready for bed, you can't have mom and dad staying up till 1, 2 o'clock in the morning to put you to bed. They have to get up and go to work in the next day. So how do we adjust that as a family unit to allow the kids to be who the kids are, but also so the parents have a good night's sleep? And then the last thing is the parents need a good night's sleep. If the parents don't have a good night's sleep, they're not going to be as effective caregivers the next day. So this is a family dynamic. So the child may have, or the young adult may have an issue, but it's going to impact the family. And looking at it globally is, I think, a key thing to helping family dynamics and keeping everyone healthy.
So do you need both a sleep specialist and a general pulmonologist? Or is there an indicator that says this family does, this family doesn't?
I think it depends. I just wanted to add one other, sorry, I'm not meaning to hog the microphone one bit.
This is your bailiwick, it's okay.
When it comes, it's an important concept to understand too, but when you snore, right, your upper airway is vibrating. But you need a certain amount of strength for that to happen, right? Because you have a vacuum, your diaphragm is firing and pushing down and sucking in your upper airway. If you have muscle weakness, you might not actually have the strength to snore. So you could still have sleep disorder breathing, but you're totally quiet. Other thing when it comes to treatment, like CPAP in general is intended to just stent open the upper airway, not give you a good breath. Like CPAP in neuromuscular disorders, not really a thing, right? So it should be bilevel PAP. BiPAP is a coined term by Respironics, but or non-invasive ventilation. So.
To directly answer your question, do you need both? So I think it depends on who you're working with. So for instance, I'm only pediatric pulmonary trained, but I know my limits, right? And all of us are not all-knowing, correct? And so I think as you work with your physician group, whatever your team is, if you feel there's a component of your child or yourself's care that's not being addressed, you should bring that up and say, hey, I think there might be something different that's happening that's not just my breathing, that there's actually something about the sleep portion that I want addressed, or and have a conversation about it. If you feel like you can't converse with your team about it, then potentially you could try to seek another opinion. But typically in my practice, I know where my limits are when it comes to supporting a person's breathing. And if I think that the person is going through some other issue with insomnia or some other facet of sleep that I don't know how to treat, then I do lean on my colleagues with it, which is still in my group, to help me. And so I'll either ask them on the side, or I'll have my patient see them one time to say, hey, can you address this one part of their sleep to help with that? And I don't know if that was actually your true question. Yeah, because one thing to think about is, your condition is just one piece of you. You can have other things too that also contribute to either poor sleep or poor breathing during the day, and so that needs to be addressed.
I'm just going to add one more thing, because there is a great push, and we've recognized this among our patients. There's a great push to push, for bone health. Everybody thinks of calcium and vitamin D, and we went through this phase where they were pushing a fair amount of calcium distributed throughout the day. And what we recognize is children with neuromuscular disorders may not manifest the classic sleep-related issues we see during sleep studies as a consequence of iron deficiency. So the rest of the population will twitch and move a lot in sleep, but when you have a muscular dystrophy, you don't see that. And that's called periodic limb movements. So we have now recognized among our neuromuscular patient population that a lot of them don't have good, robust iron stores. And it goes back to how are we positioning a multivitamin with iron? You can't take your iron with your calcium, vitamin D. So that's a whole separate slew of discussions. But it's something to consider that these individuals are at risk of becoming iron deficient when we just push for calcium and vitamin D supplementation without regard to other trace elements. So those are the things that can also impact what we call sleep continuity through the night. So they'll twitch and wake up, and they're tired when they wake up, and it has nothing to do with breathing.
Thank you for lending your expertise to this conversation. It's very useful. I have a couple of questions that maybe stem out of some of the things that have already been said. So one relates to sleep duration, which I hadn't considered before this conversation because I have a 4-year-old that sleeps like a teenager and he's ventilated. This is the first time I've sort of thought about that. So I'd be interested to hear any comments on that. I also have a question about, is there a common pattern in children with neuromuscular conditions where heart rate dips in deep sleep? Okay, I'm already seeing nodding. Heart rate dipping in deep sleep. So not dipping to a dangerous level, but maybe into the low 60s, high 50s.
Tell them what your child's subtype is.
It's nebrulated Nemelin myopathy. And then my last question is an upper airway question around whether pulmonologists and sleep specialists participate in care around like the palate and the tongue and how to work with pulmonologists or who to work with, aside from a dentist who has a different perspective, to address those kinds of concerns and how they might impact breathing and sleeping. Thanks.
Okay, first question on sleep duration.
Well, children with neuromuscular conditions should get the same amount of sleep as their, for lack of a better word, age-matched controls. In other words, if you're 7 years old and you should be getting 10 hours sleep, that would be a reasonable target for someone with a congenital muscular dystrophy. So I would go in with the idea that we're going to treat them the same way. Now, the question is, if you're not getting that, why? What's getting in the way? Is it tube feedings at night that wakes them up? Are they needing airway clearance? Is their mattress uncomfortable? Really simple, basic stuff. What is the parent's bedtime? What time does the kid have to get up for school? We've taken care of a lot of schools. The kid has to get up at 5 in the morning to get there by 8 because there's only one bus that picks them up. But you can't make that child go to bed at 7 o'clock to get 10 hours of sleep to get up at 5. So what strategies can you offer to work around that? Can you get a special bus? Can you drive your child to school? Would it be better to do morning classes by telemed until they're awake and then get them into class because it's really important that they be around peers so they can have normal childhood activities? So it seems like a simple question. How do you get enough sleep? It's the opposite question. Which is? A lot of duration. A lot.
He wants to sleep more than you think he's...
Doesn't want to get up.
Well, then the question would be, there's normal variance. Some people, I get by on 6 hours, my wife needs 10 hours. But between the two of us, we average 8 hours of sleep, and we're doing pretty good. Are they a longer sleeper? Do they just need more sleep time? But then you look at the physiology, is their sleep quality good? They may be going to bed, but are they having little micro obstructions? Are they hypoventilating? The restlessness that doesn't appear in their legs that Hemant was talking about, are their iron stores proper? Are there medical things that are impacting on their sleep? So you have to look at the whole picture. If everything is quote unquote normal, their oxygen's fine, CO2, no airway obstruction, they're ventilating well, and they wake up in the morning refreshed, they just may need more sleep.
Is your son on mechanical ventilation?
Yes.
Okay. Have they had settings checked recently?
Yes.
Okay.
And the nice part about some of these machines too is they provide us downloads, right? And so being able to look at that download and see, and admittedly it can be tough because if you're on 24 hours, you can't necessarily catch, if you're on 24 though, it's sometimes the average data that's outputted encompasses both daytime awake and sleep, right? And so it's hard to see like what is actually happening at night. So the downloads can help, especially since he's just on at night. But if he's breathing really fast at night, but his O2 and CO2 are okay, perhaps you could envision needing just higher pressures. He's actually working, trying to keep up with it. Granted, he has pressures to help with the breath, but he's asking for more, right? And so perhaps it's a little titration could make you have more restful sleep too.
I'll take the part about upper airway, tongue, palate. Usually ENT and speech therapy together and deal with that. In my institution, that's who does it. I imagine there's local variations in that. I wanted to hear more about the variable and low heart rate during sleep.
Don't look at me.
Yeah, we're looking at you.
I mean,
I could make up an
I don't
answer,
think
but I'm not a sleep doctor.
so by itself, if there's good saturation and stability, I don't see, if someone is fully supported and hits really nice deep sleep, why at that age a heart rate of 60 or 70 should be alarming, as long as it's a normal, what we call a sinus rhythm. So that's again one of the benefits for getting a sleep study overnight is that we can look and see and make sure that the EKG portion of that looks okay. Sometimes our cardio folks will actually just get a monitor that you can wear overnight, sometimes for a few days. So it's not unreasonable if to put that, if it worries you that much, but I'd say I wouldn't be alarmed. I think at this age, in fact, everyone over here who's ever dealt with an apnea monitor in infants will tell you that we have turned our heart rate alarm thresholds down to like 60 by the time the child is like 6 months old or so, because some of these kids will drop to 80 or so, and it's by the time they're hitting 3 or 4, it's not unreasonable where you can have a 60 or 70 heart rate periodically through the night and still be normal. So I'd say just check with your cardio folks if you're really worried. I don't know if anybody has anything else.
Well, we have Reghan here for her expertise. If everything is normal, when are the indications for getting a neurologist to look at brainwave activity at night?
That would be, I would say, for most of our congenital muscle disease subtypes, very rare. However, for a few subtypes, we would want to look at an EEG, and that would be the Marison deficient or LAMA2 related congenital muscular dystrophy and alpha-dystroglycanopathies, where there can be a risk of epileptiform activity on the EEG, but otherwise, if we order a sleep study for most of our patients, we wouldn't need that. In fact, as neurologists, we primarily focus on what is the CO2 and was the CO2 monitor on the entire night. That's the most important thing from our perspective.
Hello, I'm Sandy. I'm a proud mom of a college and 6 kiddo here. We have the privilege of being seen at the Children's Hospital and working with Dr. Foley at the NIH. And we are just in, Roland doesn't have to do sleep studies quite yet, but the question I feel least equipped to answer confidently is when the pulmonologist asks us about sleep. Is he sleeping typically? How is his sleep? And I think in the multivariable equation that is childhood, there are nights that you're excited about something or nervous about something. And so I always feel just a little bit nervous, accurately answering to your point. Like these are small, nuanced things. Dad snores, does he, all these different dynamics. And the stakes are high towards when that sleep study happens. A big yawn there. See, is that concerning? Or
How old is he?
No, but so I guess my question is specifically, is there a benefit to sleep trackers? Like I'm thinking about the technology of an Oura ring or these different monitors to be able to bring some data to that conversation beyond all the specific tiny things we see as parents. before a big sleep study so that we can inform that important decision.
How old is he?
How old? He'll be 9 in October.
Okay.
So I'll take the first part of that question, which is your caregiver parental anxiety of giving the wrong information or not all the information to your clinician who's taking care of you. It's a conversation, right? So the clinician is trying to get information. So you start off with, how's your sleep? And if the clinician isn't hearing what they need to hear, then they'll ask follow-up questions to get the key things that they're looking for, which is, does the child sleep through the night? Are they waking up in the middle of the night? They'll ask about the breathing. They will ask about morning awakening and morning headaches. They'll ask about their alertness during the day. So there will be follow-up questions. It may or may not happen with every visit, right? Because for me, I do try to, I have a checklist of what I want to cover, but if it doesn't, if I don't have the time that visit, I can just talk about the next visit, right? There's a whole thing that I love about pediatric pulmonary in this community is continuity. I get to see you again. It's not a one-time appointment. But the trackers, I would like to hear from the sleep docs what they think about them.
I want to hear what Hemant says.
You're about to raise it.
Oh, I hate it.
Thank you.
Here's the thing. What is hard about sleep trackers is you get information, you don't know if it's good information or not. But the one thing it is going to do is stress you out. I don't routinely advocate it. In fact, we don't even have one in our household. If you're not sleeping well, it's a conversation to be had. If you're sleeping well, it doesn't matter what the tracker says. And my school friends, going back a few decades, some of them wear this aura. He says, it can tell me where I'm coming down with something. I'm like, you guys, you've got this crystal ball. I should be giving it to all my kids over here to say. And 3 days before they get sick, we should be getting calls like, hey, something's coming down. And what are you going to do with that information until you actually get there? So it's like what I tell our trainees also. Do a test, the results of which you're ready to do something about. Don't do a test just because. And some of the sleep tracker stuff is exactly that. You have a pulse ox. I think the iPhones. I'm not into the Mac space. I'm kind of a Windows and Android, the better side of life kind of thing. But they had come up with this pulse ox device, and people were flying, and then, there was all of this alarm about, oh wait, my oxygen levels on flight were lower. Like, was your finger cold? Was the device too cold? I mean, there's so much variability that I feel like if these people are going to give you a tool for sleep tracker, you should take your information, give it to them, and let them be the ones to counsel you. Right? But they don't want to do that. They say, here, take this tool, go make your dog miserable. I'm sure there's a time and place for everything, and there's probably some benefit to it, but I feel to extend that into a population where there is no clarity. I mean, I'll tell you, even in a neuromuscular space, there's no clarity in the sleep lab right now. Yeah. Forget tracking devices in the neuromuscular space. We're talking about decades further of evolution of quality of information. So I'd be careful about extending your confidence into any of these technologies. What is the microcirculation like on the finger or the shoulder of, a teenager in the middle of the night? I mean, I can tell you peripheral circulation is not the same in someone who doesn't have muscular dystrophy versus someone who has. So your information is going to be colored by so many different variables when you use some of these devices.
These devices were not made for us.
And I rest my case.
To answer your question too, I completely agree. I don't recommend it. When we track sleep, it's usually to look at circadian rhythms. So it's for people who we think might want to go to. We don't really know what their body wants to do, and so there's medical grade devices that we can use then. But to answer your question, there are studies looking at how good are these devices, and I know a lot of them will say, I had like 15% REM sleep last night. I got the green thumbs up, and that it's not. I think the data says that it can predict the sleep duration okay. It really can't tease out like the non-REM and REM, to my knowledge. And maybe, yeah, exactly. And so no further, like I completely understand or agree with what Dr. Sawnani said, but to answer, they're good to an extent, but not phenomenal. Maybe someday they'll get there, but agree it's just more stress. I wouldn't worry about it one bit.
Yeah, and I agree too. And the only thing I have to add, remember, this equipment, first of all, it's not been validated. It's just, you don't have to have a very hard bar to clear to get that stuff, to have that tracker on display at Costco and for someone to buy it. So it's not validated. It's also designed for people with no medical comorbidities. So that's just an average person with no health issues. They're otherwise well. You start adding in neuromuscular weaknesses, you start adding in hypoventilation because of it's not even designed to do that. Now, having said that, people are going to buy this and they're going to get the downloads, and that's just the world we live in, and it's fine. The best advice I would get is if you collect that data, interpret it with a grain or a pound of salt, whether it says everything's normal or everything is not normal. And then if you have concerns or questions, you bring it to your pulmonologist, you bring it to your sleep physician and goes, what do you think this means? At the end of the day, we're going to go, well, how's your kid doing? And then we'll base our information off of that.
I mean, if we could have medical devices that worked, we wouldn't have to go for a sleep study with 47 electrodes on our head and our finger and our chest, right? Like, there's a reason it's complicated.
Oh, yeah. I mean, I think at some point, a lot of sleep labs will go out of business. The technology will be so much better that we can study patients, children, families in the home. We already have that for basic middle-aged men and women with classic OSA symptoms. But we're not there yet. The technology will get there, but it's going to be probably a decade or so away, if we're lucky.
One other comment on home monitoring. I practice at altitude, so all of my patients think that they need oxygen at night, and none of them do. Some of you with infants may have heard of the Owlet device or have even maybe used it, and I've had arguments with pediatricians in our area. It is not FDA approved. It is FDA authorized, which means the FDA says, sure, you can sell that to people, but it doesn't mean that it's worth anything, that the data that is collected is validated at all. So just know if you're using an Owlet and it says FDA whatever on it, it doesn't mean a lick.
Actually, can I add one caveat to that? Because I was at an American Academy of Pediatrics meeting a few months ago, and I went up to the Owlet display, and I had a lot of steam under my collar, waiting to go, you're ruining people's lives with that. Oren's 100% correct. The one that you can buy is not FDA certified for effective monitoring. There is an Owlet that is FDA approved, but it has to be prescribed. They use them in hospitals, but it's a very special piece of equipment. You can't purchase it on your own. It has to be prescribed, and it's quite expensive.
I'm just going to hopefully be the last one to add this statement that, when we have our patients, I tell families, I don't want you to look for problems. We will quantify it and we will objectively test and then go from there. A good history is incredibly helpful to determine what threshold we need to have for sleep testing. Beyond that, don't try to do any testing at home.
And just one thing, I'm with Cure CMD, and we have a series on YouTube that a lot of these clinicians participated in 4 years ago. We had 2 of our teenagers interview several of the doctors, and it's a great, great series, so please look for that on Cure CMD's YouTube site.
Thank you, good morning, and thank you so much for this moment. Okay, my question is about the pneumothorax, is because I would like to know if there any emergency protocol that we as parents can follow or that it just report any symptoms. Because the last time that was and the first time was about 2 months ago, and we are in the car, and in this moment she begins to feel something like heart attack, because the first symptom was I had a lot of pain in my chest. I couldn't breathe. And when I asked, where is the pain, she said, in the left side. And I just would like to know if that we as parents can do anything at home while we are just to go to the hospital or something. Thank you.
So I said this in the young adult session before. I was asked about pneumothorax as well. That's my nightmare, because you need pressure to breathe, right? You need that pressure, but the pressure will drive the pneumothorax. It will increase the size of it. You can't treat a pneumothorax without breathing, though. So you have to have non-invasive ventilation, and then we'll deal with the pneumothorax after that. But if you take away BiPAP, for instance, and try to treat with oxygen alone or with just a chest tube, it's not going to work. The pneumothorax came after the CMD, right? So let's treat the CMD first. That's BiPAP. And then let's treat the pneumothorax. But it is a very challenging situation to be in. And I don't know if, Rachel, you want to
I told you in the young adult session, I've had 11 pneumothoraces, and most non-expert doctors don't know what to do with it. And yes, they want to put you on oxygen without mechanical breathing support, and that's a huge no-no, right? There's 1,000 other problems that will crop up because of that. So maybe you have to reduce your pressures a little bit so that it doesn't hurt so much until they figure out how to repair the pneumothoraces, but you have to have breathing support.
Maybe I could just add a little bit of background. So it's more common, most common, I would say, in the collagen 6-related congenital muscular dystrophy subtype. Amongst the collagen 6 affected individuals, it's rare. So we use our collective experience. We know who in the communities had them, and some of them are here to talk to you about this, but we often have to be in communication with the medical team because it's complex for them to manage. But it sounds like your symptom onset was acute pain, and it came on in the car. We've had some patients in our community who had car-related onset of pneumothoraces, but it's complicated. We did do a paper a few years ago with colleagues of ours from Canada on our collective collagen 6 experience with pneumothoraces. Again, I think the key take-home point that Dr. Kupfer said was you need to stay on pressure, but manage it carefully with the chest tube. So some of our mantras still hold: no oxygen without BiPAP, and then making sure you're optimizing pressure while carefully also addressing the pneumothorax.
And if you need a chest tube, it needs to be done with interventional radiology. Don't let them just do it by feel, because they're going to miss. And I can, if you email me, I'll send you that paper.
Hi, I'm Megan Leach, neuromuscular from Oregon. And so as a clinician, when I'm reading notes for some of my younger patients and from the pulmonologist, and they'll be like, oh, everything's great, and like they haven't had a lot of respiratory infections, and so great, bye, see you in a year. And so I know the importance of chest wall mobility. So when my patients go to the pulmonologist, who's not a neuromuscular specialist, and they say everything's fine, how can the families advocate for a cough assist device to help with that chest wall mobility before the kid develops the contractures, before they're in the hospital with pneumonia and all of these things, to be more proactive when the pulmonologist is like, oh, yeah, you're fine, bye-bye.
You know, this brings back a memory when I saw a patient from Waco, Texas, about 10, 12 years ago, and the pulmonologist there wouldn't prescribe a cough assist until he had 2 pneumonias. I don't know where this came from. The only recommendation I have is just have the family reach out to maybe the organizations like PPMD, Cure CMD, to help leverage that information so they can advocate better for their child. I think it's incredibly frustrating where in this day and age we would find people, I mean, we have these battles fighting with insurance companies to still approve these devices. Don't get me started.
Yeah. I think just in terms of saying what we look for when to start as well. Some key things, not just recurrent infections, but how long are they? Do you have a weak cough? Do you have trouble coughing up secretions, et cetera? We also know that even if you're okay, again, we'd rather be proactive, not reactive, right? And so you would think it'd be in the interest of insurance companies to prevent those admissions, but that's a whole nother story. So I would say I wanted to provide those things. I encourage you to be honest, but just, if you decide you want to say, hey, we have a weak cough and it takes forever to get over it, those are things that, yeah, you should be starting cough assist. So as families, you can advocate more. There's resources. There's also, I think, once you have a cough assist, one size doesn't fit all necessarily in regards to settings. And so that's where I think Mark here can talk more about how we approach cough assist settings to get that stretch too.
Yeah, I think that getting authorization for medical equipment is definitely an art, really, because there's just so many different payers that we work with, meaning insurance companies or state insurances that we're working with, and different vendors that will have different criteria of whether they will take on the case of the cost of the device working with the patient. And so, I often will warn, for the families I want to be proactive, I warn that my letters of medical necessity are going to sound like gloom and doom and then your child's dying, because I need to say that in order to get your device, right? And so depending on who you're working with, they may not be aware that you want to be proactive. There are different thresholds that people use to start different medical devices, and so that's why that conversation is really important to be had. And even if you're a clinician elsewhere, I often will reach out to my other colleagues and just say, hey, this is what the family's telling me with a one-time, because I'll see one-time consultations, and I'll go back to their primary person and say, hey, this is what they're looking for. This is how you can get it, and bridging that gap, because sometimes other people who don't work in this space might not know those tips and tricks, and that's where I learn so much from my families is, how did you get that piece of equipment that I've actually been trying to get for this other patient over here, and I learned from that. And so it's and so as clinicians, the bottom line is people are here to help you, right? The clinicians who you're seeing are here to help, and so it's helpful for them to know what you're looking for and why you're looking for it.
Mark, you want to talk about?
Yeah, so just to echo John's point, in our clinic, we try to be as proactive as possible. So when we're seeing more belly breathing or less chest wall mobility, those are the reasons why we know that the cough is not going to be as effective. They're also breathing because of the restriction in their chest wall is they're not going to have higher airflows. And so getting hyperinflation exercises started soon as possible is more effective sometimes than how compliant you are. So if we can get cough assist and hyperinflation done early on, maybe as young as 6 years old, and getting it approved is a whole different animal and issue. But as soon as we start seeing those type of things, those restrictions in airflow, that's giving us the indication that we need to start these type of treatments and exercises, and that's kind of where I come in to titrate settings, inspiratory times, pressures, those type of things. But it's an individual treatment type thing, more of an art than a science. Knowing how well the settings that you're putting in for each child is able to move the chest wall and able to end up moving mucus when you have it down there and need to actually move it. So that's why I'm available to talk on some of these things later on in the conference. I'm going to kind of show you guys how we use both pressures and inspiratory times and expiratory times to create the outcome that we want.
We have an exhibitor, Millennium Respiratory, in the lobby, and Mark is going to be working with them and their equipment to do demonstrations and answer those specific questions about titrating settings.
Hi, my name is Kim Koto. My son is an 8-year-old with titanopathy. He uses BiPAP at night. Our oximeter, we know that the number on the left is O2, if it goes low, the alarm goes off. The heart rate's on the right, if it goes high, the alarm goes off. In the middle, it's just a pulsating light. And what I believe it is the breathing rate, and you guys had mentioned that? No. Okay, well, that alarm has been going off a lot lately, and we want to know why, and what could we do about this, and what is this?
The pulsating light is usually just it's a qualitative signal to you, the viewer, of the pulse waveform that is being appreciated at the fingertip. So if, like I said earlier, I don't know what their circulation is like and whether or not there are phases of sleep where, circulation is a little, some of the titanopathies also have cardiac underlying issues, and so that might be more of a concern there. Not meaning to alarm you, but it's just that if you're hearing alarms of the pulse ox signal, it could be as simple as a bad probe.
It probably is, because we only get 2 a month, so I guarantee that's probably it.
So that, I would say, before we think any medical, let's just treat the instrument first, and then you can see from there. But usually, if it's just a signal alarm, not of the low heart rate or low oxygen level, but just, it's probably a technical issue with the contact.
Okay, thank you.
Yeah.
Hi. I have a question about devices, and specifically about the companies and the medical equipment suppliers, because so my name's Josh. We live in Toronto. Gabby's 14. She uses a vent and a trach at night and sometimes during the day. But she had to change her trach because they discontinued her trach. She has to change her Trilogy vent because they discontinued her vent. She has to change her cough assist because they discontinued the cough assist. There's no good solutions for humidity on her vent when she's not connected to a wall, right? Because she needs humidity. And it seemed, when we talk to our doctors, there doesn't seem to be a good connection between the medical practitioners and the suppliers of the equipment, and even the different suppliers, like the vent and the humidifier are different suppliers. And so, and the medical equipment, there seems to be a real gap in the care that can be provided in quality of life with all these changes and things like that that aren't quite addressing needs. And the doctors don't just sort of put up their hands and say, sorry, we can't do anything about it. So that doesn't seem to be good enough. Like, how can we make better connections to the equipment suppliers, to the vendors, that they're actually meeting, like, that they're not discontinuing from a business decision when this is your life, right? Like, so I don't know if you have any thoughts on that, and specifically a question about humidity on the go for a vent, because we're basically inventing a system with portable batteries because there is not a good solution for humidity on the go.
Well, I'm curious, does your child use a inline HME to help humidify?
Yeah, she has a reaction. It doesn't help her. She really needs humidity, not just an HME when she's ventilated. So we have a system with a portable battery and an older humidifier that doesn't use as much power, that is working, but it's not ideal because the battery dies after an hour or two. So. Yeah, and she has an Emeline myopathy. Nebulin. Right.
So yeah, I've actually seen this thing come up with some of our patients, and that is a struggle, right? I mean, you're worried about drying out, and you're worried about plugging. What I tell my patients and families to do is to always have saline bullets on hand, normal saline bullets, and just put a couple drops down, maybe every 30 minutes to an hour. I know it's not ideal.
Don't waterboard her.
Sorry?
Don't waterboard her.
Right. Yeah. Without waterboarding, right? So, but a couple drops of normal saline really does go a long way instilled directly right into the trach. Does go a long way to keeping the airway open and the trach open and free of drying out mucus and plugging. So yeah, I know it is a struggle though. I mean, it's just one of those things that you have to stay on top of. And but yeah, the saline bullets I feel like really do work in that situation.
So I've been poking you guys about once a year for the last couple of years, knowing that, the machines we've been using for 10 plus years are all being discontinued. And you guys have been giving me some ideas about decent replacements. You want to share those?
Sorry, what was that, Rich? We were mumbling to ourselves.
The replacement for the Trilogy, the replacement for the Cough Assist, all the stuff that we've been counting on forever is now being discontinued.
So now more than ever, we have multiple ventilator choices. There are, for adults, at least 4 in the United States. And with that, with those increased options come less power for us to be able to decide which ventilator someone uses. The Trilogy 100-202 was a revolutionary device at its time, and it was essentially a leap over the older ventilators. That then opened the floodgates for new technology to be developed, so multiple companies now have ventilators, and I think what's ended up happening is that insurers and DME companies would like to only choose one most of the time. So that's one of the problems. As far as it not being good enough, 100% agree with you that we have to have very good relationships with our local DME companies. And thankfully I have staff who routinely call the DME companies. I think we actually have monthly meetings with each of our local DMEs to talk about quality issues. So asking that of your respiratory care department is not unreasonable. And then for portable humidity, I think we have someone in the room who could better answer this question than us. We have, if willing to help or to describe what you do, we have someone on a ventilator in the back of the room with portable humidity.
We have her 850 mounted to the chair, but we don't have a portable battery system that powers it because my other 850 died upstairs in the room, plugged into the wall. So that is great. I'm praying this one doesn't blow this weekend because then I'm really in trouble. But we have it mounted to the chair so that when she's in class, her teachers all know to assign her a desk that is near a wall plug. And so since her classes are 90 minutes apiece, then wherever she's in a class that she's sitting most of the time, then we plug in the heater so she gets that humidity. And then for kids who are not vent dependent and who are able to be upright, we use a Shikani HME or a Shikani speaking valve. So it's a ball valve instead of a flap valve like the Passy. And it has less resistance, so it's not as hard. And then it has a mushroom HME on top of it. And that really helps her to be humidified when she's not, doesn't have access to a plug.
I have patients, again, I'm in Colorado, very, very low humidity. So we have humidification problems all the time. And the best solution we've come up with is what you do, which is a battery pack, usually from Jackery, lasts an hour to 2 hours at a time. And unfortunately, that's as portable as we can get with active humidification.
That's what we're doing. And what humidifier goes with, we have the 1 to 2 hour battery, and we are having trouble getting our physicians to agree to the portable humidifier because the one we have at home at night is too strong for the portable bed, the 850. So we like to be able to use the HC 150 or the 410, which is, so do you know the actual humidifier that works that you guys recommend for the portable battery?
Do you know? That is a technical question beyond my capabilities, but the standard F&P, Fisher & Paykel ventilator humidifier should be able to plug into the Jackery battery. That's what my patients have used.
Something else just to consider in terms of the plug-in issue and being portability too is if you're able to, if when you're on the ventilator, you're able to have a cuff up too. I don't know if you have a cuff trach or not, but yeah, it's pretty we use a lot of cuffs just with pediatrics, but in our center too, and it's center to center dependent. But with our ENT group, if you have a trach, you basically have a cuff typically. And if you think about it with a rigid chest wall, if you're blowing pressures in there, is the chest going to move really well? Maybe not, unless you have, and sometimes even with a cuff, it still doesn't move great. But the reason I bring it up is because the ventilator is using flow to achieve pressures, right? If you're sweaty and you step outside, today's pretty nice outside, but when it was really hot, you're sweaty, it's windy, right? The sweat's gonna dry quickly because of convection. If you're uncuffed and the ventilator's trying to reach those pressures, it's ramping up flow, and you can actually sort of desiccate secretions and become pluggy. So I've had some patients where just going to a cuff trach, all of a sudden your problem is gone. And then when you're off the vent, you can take your cuff down. You could have your cuff down on the vent too, but if it's an issue, it could just be a matter of safely doing a cuff. And when I say safely, you want to make sure you're not just jamming in a ton of water in the cuff, because you can actually cause problems by being too tight. So you want to have some leak, but not a ton of leak. The other thing is what medications, if you have any like Robenol on board or glycopyrrolate, scopolamine patch, anything like that, that can contribute to, thicker secretions. But other thing is the spine can compress airway sometimes, depending on the curve. And so if you have some airway compression, and on the ventilator, you're able to get past that compression and mobilize secretions, but off the vent, then all of a sudden it's harder to aerate, and you sort of build up secretions over time, and then you can plug. And then once you get back on the vent, then you mobilize them, and you might get really junky initially and have to clear those. So I think we don't shy away from the cuff trach necessarily, and again, just because you have a cuff doesn't mean you have to use it, but it can be very helpful in these settings too.
I have a cuff trach. Also, my wheelchair has an inverter installed, and I run my ventilator off of my inverter through my wheelchair battery all day. So that's another option to look into. Yep.
Dan Byler, just a quick question. Our pulmonologist is insisting that my daughter, on her cough assist, that she does exhales, forced coughs, as well as the just breathing in, and I'm pretty sure that here I've heard you don't need to do that. You make her cough when she needs to cough, but don't do it all the time. Can you address that?
This is the dad of the kiddo who asked in.
Right, I want to see how other people answer it.
Yeah. So cough assist serves two purposes. One is to hyperinflate your lungs and your chest wall to get some expansion, right? And the second is to help you cough if you need to expel secretions. So both of them are important, but you may not necessarily need cough as much as you need the hyperinflation.
Exactly right. You don't need it. You don't need me. So that's exactly right. So for chest wall mobility, chest wall flexibility, I'll do the inhale only for a certain inhale time with repetition to expand the chest wall, and that's daily practice for patients. I have thresholds that we use with certain numbers that we use, but it is also about how much the family or the patient's interested in being proactive in keeping chest wall mobility. Then the second approach is using it for mobilization of central secretions, and that's where you have insufflation and exsufflation. I wasn't sure if your question is, do you cough on the exhalation portion? It depends. Most of the time, I don't say the patient needs to cough during the exhalation because that's what the machine is doing. It's pushing air in, pulls air out to help move secretions that are potentially further out more centrally than the person can swallow at the very end. So I don't know if I clearly understand the question, but we do both lung volume recruitment with it and mobilization of secretions, and the frequency of each depends on what the person needs.
Yeah, just to piggyback on that point. So the inhalation is just as important as the exhalation. So you can't move mucus without putting air behind it. So if you can't get air down in the lower bases of the lungs, then you're not going to move that mucus. To the point about having to cough afterwards, I don't personally tell my patients to do that. But because the cough assist should be effective and be mimicking a cough. But you can. I mean, I have no problem doing that, but I think getting the airflow down to the basis of the lungs by using the longer inspiratory times would help to move that mucus as well.
Yeah, just to clarify, I have the patient cough at the very end. I don't have them cough during exhalation, during the exhalation portion of the device.
So I'll muddy it even further. We all cough every day at random times. So, and we, meaning those of us who have relatively normal respiratory muscle function, we cough and clear normal mucus every day. And so why shouldn't someone with respiratory muscle weakness have that same opportunity? So you should probably cough a few times a day with the cough assist machine if you have a weak cough. The most important part, actually, I wouldn't even say just as important, most important part is the inhalation. So if you're gonna do anything, but only one thing, do insufflation therapy. And if you're, but it's never wrong to also cough to do the expiratory phase.
Just an easy exercise to show that point of the inhalation. So take a half breath and then cough. Now take a full breath and then cough. A little bit stronger. There it is. Okay. So you have to get a good deep breath and fully reach your total lung capacity essentially to get the most out of it. And then one of the most important times, completely agree. One of the most important times to get it is after you sleep, right? Things sort of are settle and they need to move. So if you're going to choose a time of day, I always say when you wake up, maybe before bed to clear it out before you go to sleep too.
We have Sarah's question, and then I'm going to have my last question. You guys have opportunity to also ask. Exactly. So we have opportunity in your subsite breakouts to ask more questions because we'll have respiratory people in all your sessions. So, Sarah.
I'm thinking, can you please explain why oxygen isn't, there's cautions with oxygen in our communities and with breathing muscle weakness, why it's not just a cure?
Can you repeat her question?
Yeah, I'll repeat
first?
the question. Why is oxygen dangerous, and why should we not use it without pressure? Am I paraphrasing okay? Yeah, okay. I'm going to hand it off to others. I've already answered this question once today.
Actually, it was a really good answer, so you should do it.
Okay, fine. I'll do it. I have to find the right MP3 in my brain. Okay. So there are two reasons that we breathe, or two triggers for breathing. One is oxygen and one is CO2. If your oxygen gets too low, your brain senses this and says, breathe deeper, breathe faster. If your CO2 gets too high, your brain says, breathe deeper, breathe faster to blow it down. In neuromuscular conditions, sometimes the CO2 is a little bit higher already because of respiratory muscle weakness. We call this hypoventilation, right? So the CO2 level creeps up and your brain starts to sense that as normal. Meanwhile, your oxygen is usually fine. It's usually in the 90s and your brain says that's fine. And so you just breathe the way you breathe. If you get sick, you lose lung function, oxygen goes down and CO2 rises. And if you just apply oxygen to that situation, your brain will sense, well, I don't have a reason to breathe from an oxygen standpoint, and I kind of forgot about my CO2 because it was already high anyway, and so your brain doesn't sense a reason to breathe differently. And so what will end up happening is that you won't be taking those faster or deeper breaths. The CO2 will continue to rise, and the O2 level will remain normal or relatively normal. And that eventually will lead to changes in breathing, slower breathing, and eventually apnea or no breathing. So if you just apply oxygen, you're really putting a Band-Aid on the problem while the wound festers, essentially. Right?
I'm just going to add that these responses are what you typically see in a normal individual. When you have muscle weakness, that whole breathe deeper and faster is not going to happen because you can't do it. So when you put the oxygen on and the oxygen saturations are up, the untrained observer is going to say, oh, his oxygen levels are good, I can walk away. That is where the problem also occurs. So because they don't have a similar monitor for carbon dioxide routinely being used, they're never alarmed when they see saturations are good, I'm plugging him on oxygen. So that's why we say don't use it exclusively. But if you had to, most of the time, whenever our young individuals show up in an acute setting, what really helps move saturations is putting them back on their support. And then if you need a little help, oxygen can be added. It's not a bad thing, as long as the first step, which is your bi-level pressures, whether it's a ventilator or non-invasive, whatever it is, as long as that is in place, adding oxygen secondarily is not a bad thing. But exclusively oxygen is dangerous.
And adding in the airway clearance, right, to try to clear and mobilize secretions. Other thing to piggyback on Dr. Sawnani too, while you can't necessarily see the increased respiratory rate, increased work of breathing, when you have muscle weakness, heart rate may be up. So heart rate's another huge indicator for us. Standard question, all right, sure, they look like they're not in respiratory distress, but what's the heart rate? Well, what's the baseline rate? Okay, so they're like 30 points higher, something's going on, right? So that's your other hallmark. I'd encourage you all to be, and you already are, you're here, you're advocates for your loved ones, absolutely. But in the ED, you may need to really, really pester, and that's totally fine. And you can like pull up the Cure CMD websites, the videos, everything to try to educate the team. No matter the medical center you're at, we're a pretty big institution. CHOP is too. Like all of us up here, we're major institutions, and we unfortunately fairly routinely see like some of our patients being put on O2, is the cannula or simple mask. And so we're trying to, fortunately our care coordinators might capture this, and so we'll call down to the ED and say like, hey, what are you doing? And put them on support. But just to encourage, like, it's okay, don't worry to pester, and you might feel bad for being quote unquote the hard patient, but it's because you're trying to save your kid's life, right? So do it, it's okay.
Be a difficult patient, be a difficult parent.
You know,
Seriously.
I think what John mentions is really important, that the heart rate being the indicator of stress, particularly in a patient who can't move much. And I often will tell our families, those who are even on continuous ventilation, or they have windows in the day, we all don't have the same day every day, right? All of us have variations among ourselves, and so do our children. But if you come out, if you see the heart rate go up by about 10 to 20% coming off respiratory support, that might be an indicator that someone's not having a really good day, and you may need to go back on support. It doesn't make for good energy efficiency if you say, no, we're going to pursue our 12 hours off the ventilator when my heart rate's already going up. I'm just going to burn calories with my heart while you're struggling to get me to gain weight anyway. So those days where the weather is changing, you have a storm brewing, someone may need a little more support if their heart rates are a little higher, and that's okay, okay?
All right, I have one last question for each of you. You have 20 seconds, and you can't use the previous person's response. We're going to start with Mimi. If you could have everybody can take away one thing from this session, what would you want it to be?
I thank everyone who joins registries, patient registries, because we know what we know because of natural history studies or data that's out there. And so I really applaud all of you who take the time to do that. And, you know, Cure CMD really helped lead the way for patient registries too, and that's just so important. So thank you.
Was not expecting that one.
Stole my thunder, I'm thinking. Okay, no, I'm just kidding. This is a labor of love. It's a lot of, new normals and new baselines every few months or every few years in our lives over here. So just be patient, show grace, be with, Rome wasn't built in a day, and some struggles take a little longer to get through. But just be patient.
I would say, just on the previous point that we talked about, when you come through the ED, having a care plan, we always actually have a care plan, and we laminate it for our families, is huge. And so it's either right on the wheelchair or right on the medical bag somewhere that it just lists everything out. That way, when you're fighting, I mean, we get calls all the time, but when you're fighting for your son or daughter, you have the right things to say in place. Like, and these are lists right from our orders. You've seen us, and we know your child, but sometimes when they come through the ED, they don't know your child, and sometimes they're trying to treat them like every other child. And so having a care plan in place when something happens, and having that care plan in a place where you can easily access it is huge and has been massive for all of our patients. Yeah, so basically the care plan states, when they come through the emergency department, basically what what they need as far as not putting them on oxygen, putting them on support, what other settings, and places to start, because sometimes you're rushing to the ED and you don't have your BiPAP with you, or you don't have your cough assist with you, and those type of things, and knowing what the settings are on the BiPAP, and knowing what the settings are on the cough assist, and being able to fight for those things to be readily available for your son or daughter will make a big difference.
I think I'll say maybe 3 things pretty quick. The first one, maybe sort of silly, but pooping helps you breathe, and we can talk about that later. The second one being that it does, sorry. It's, as we've already talked about, the neuromuscular community is just amazing, incredibly inspiring. Know you're not alone, right? There's resources out there. If you need help, reach out. We're all available for sure. And I know, like Reghan and I have talked about patients before, and I'm sure it's not unique, right? We all have these times where we've helped from coast to coast, and even internationally, trying to help teams out. So we're available. And the other thing is trust your gut. Something doesn't seem right, probably for a reason, right? So it's okay to say, nah, something's wrong here. One example of a phone call I had from another center was the ICU doc said, no, we have a cough assist. And then later on, I found out after the patient transferred to another institution that cough assist was a Valera machine that does no such thing. It's only like a vest therapy. So if things don't look quite right, or if you're doubting something, it's probably for a reason. Trust your gut. And obviously cough assist would have gone a long way for this patient. But.
All of these people are here because I asked them to come, not because we're paying them, so the passion is real.
Bring all of your respiratory equipment to the ER. And to prevent people from putting you on oxygen, put your own BiPAP on before you get there.
Because they'll hesitate to take you off of it.
You can't overdo it. It's not going to hurt you, right? So let's go on.
I mean, everyone said things great. The only thing I can think of adding is everyone's a unique individual. But one of the things we have in common is the vast majority of children and young adults need a cough assist machine. Many hospitals have BiPAP, they have ventilators, they have vests, they have all this. Cough assists are not that common. So if you're going anywhere, make sure you've been prescribed a cough assist. Probably should be the first piece of equipment you get. Make sure you take it everywhere, going to the mall, going to the ER. Make sure you have it, because at the end, mucus clearance is going to be the thing that knocks us down fastest. And I always think that Dr. Schreck said it best, better out than in. If you have mucus, get it out.
So from the neuromuscular neurologist perspective, a lot of this advice I can imagine as parents sounds really complicated. It's so much advice, it's complicated, but you have co-pilots, lots of co-pilots, but also the navigation in my mind comes from what we already know about your condition. So we didn't touch about this, but for each of these conditions, we already know the natural history. We know when BiPAP is indicated. We know when sleep studies should be being done. So all that's actually our big effort as neuromuscular field is to publish that so you have that on hand, so you're not navigating blind. We know your condition. So think about it within your posse. So is it Nemelin or Halogen 6 or Lama-2 or Selenon? Think about your group and interpret the flight plan off of your group. I know you have tons of co-pilots.
And mine is no oxygen without mechanical ventilation. None of you took it, so I'm going to take it. All right, thank you all. Set you off to go eat.